brings us to the next paper, which is on endoscopic excision of fiber and null of the breast. Will be presented by Dr. Agarwal and may I have Agarwal, Sarah, John. They're all from the Medical College of New Delhi in India.
Good afternoon, Professor Bonjour and Professor Lee. Good afternoon, everybody. I bring with me greetings from India for all of you. I am speaking upon endoscopic excision of a benign breast lump. The previous speakers have already shown you the advantages of using axillary approach and endoscopic surgery technique in breast surgery. Minimally invasive surgery, as we all know, has progressed because of its tremendous benefit on cosmesis. And cosmesis is very important for feminine psychology. And we all know that surgery leaves scars not only on the body but on our minds as well. Apart from this, in breast surgery, what are the advantages of applying endoscopic procedures in breast? One is absence of scar from the breast, and we all know that scar on the breast is an independent risk factor for future development of malignancy. However, exit figures are not known, and it's been said only in one paper recently. And we all know quality of life is closely linked to scar on the breast in females. Apart from this, scars on the breast, including the circumarular scar, they can be cause of pain during lactation, and even the circumarular scars are not cosmetically perfectly acceptable, as is evident from widespread sale of silicone patches applied circumarurally to reduce the scar. And as I already said, the breast scar is an important social and psychological factor and affects the quality of life of the lady. This is just a clip from the website which is selling circumarular silicone patches to reduce the scar. So what is the solution? As you already saw, we can approach the breast from the axilla. There is only one single case reported in literature, and to address this problem of cosmetics of breast, people have tried ultrasound guided extirpation of the lumps. They have tried radiofrequency assisted triablation, and even plastic surgeon colleagues have modified the circumarular excision by making it zigzag so that it is more acceptable cosmetically. So what I do, this is our position, like the patient is tilted on the ipsilateral side up, the arms are extended to around 90 degrees, and the surgeon is standing on the side of the lesion. Now, these are the two videos showing a lump. One shows the lump in the inferomedial quadrant, and I'll be coming to the other video. So first trocar is put, we get the skin incision posterior to the anterior axillary fold, and then we slide the skin with our left hand and push the trocar, that is a 10 mm trocar, bluntly on the surface of the pectoralis major, and guiding this direction of the trocar by the left hand of the surgeon who keeps on palpating the lump. Now these are the videos. The initial dissection is like what we do in extraperitoneal repair for the hernia surgery. We use only telescope for the dissection. The earlier case report which described this technique, the breast lump was using balloons, but we have never used balloons in hernia, so we utilized this experience to make the space. Initially we started using two working ports, but now I am showing a video when we are doing only two ports. One is optical and one is working. So as you can see, the space can be created easily with the help of the telescope by going and identifying the vascular planes. And once this has been done, another port, working port, is made according to the location of the lump, and also located along the anterior axillary fold. Now we go all these benign lumps, we know they have a well-defined demarcation or reciprocapsule. We try to explore that, and we go all around them. We use blunt and sharp dissection alternatively. I avoid using energy sources in laparoscopic surgery because it destroys the field. I have already published laparoscopic cholecystectomy without energy sources and other surgeries. And this has also been accepted for publication. Yesterday only I got an email in surgical endoscopy. So by following this plane around the benign lump and using sharp dissection whenever we encounter resistance on blunt dissection, the lump can be gradually shelled out from its nest. As you can see, the left one is a bigger lump, the right one is pretty small. If the lump is big, as I show you, we draw it out with the grasper and cut into different parts at the level of the skin. Otherwise, a smaller lump can easily come out through the 10 mm trocar. The right side space has been created by 5 mm telescope and the left side is 10 mm. This is 2-port technique. Initially we were using 3 ports. So the third port, the left hand of the surgeon works as a third port because you can manipulate the lump and control and guide your dissection with the left hand. Now once the grasper is introduced and the lump can, if it is small it comes out easily as you see now, and if it is big at this level we incise this lump into 2 parts. From January 2002 till March 2005, that is the period when we were using 3 ports. After that I started using 2 ports. We operated 9 married and 5 unmarried ladies for 18 lumps with a median age of 25 years. The lumps were located in all the quadrants as is shown here. The mean operated time was around 1 hour, the range being 40 to 110 minutes per lady. And because there were 4 ladies with 2 lumps, so the mean time per lump was around an hour again. In early post-operative results, we didn't encounter any surgical emphysema. There was no evidence of any injury to axilla, no bleeding, conversion or technical difficulty or rehospitalization. All the ladies could resume their activity and they could take their bath, complete the commitments to self, family and society, the normal diet and normal exercise, and then for family and fun. So by the third post-operative day, they had all A2F activities normal, and we did not use any painkillers, only paracetamol was used on demand. And on their subsequent visit to our clinics on third day, we didn't encounter any collection, hematoma, bleeding or any upper limb symptoms suggesting any injury to the axillary structures. And all the lumps that we excised, although we had a thorough preoperative workup and post-operatively also, they were all benign. Now this is, the lump was located here, and you can see this is the 10 mm trocar and this is 5 mm. And we discuss all these things with our patients and we ask them what kind of clothes they want to wear. The position of these boards can also vary, and we have found that it is easily accessible from any angle. All the ladies were very happy, appreciated our effort, that was our biggest reward. And in a society like India, an absence of cut on the breast is a big thing, especially for unmarried females. Thank you very much for your kind attention. Thank you.
Thank you very much. Very elegant technique. Are there any cultural implications? Is there a maximal size that you would consider? Are there any other diseases of the breast which would render the less likely procedure?
Very good question, sir. We worked up all our patients preoperatively to exclude any suspicion of malignancy. Only those patients who had definitely benign lesions and lesions were mobile, mostly fibroadenoma, they were taken up. And size was no contraindication. We have excised up to 7 cm of fibroadenoma with this technique. The left side was around 5 cm, and in these cases we bring them out to the skin level of the 10 mm trocar and make cut into pieces and pull them out.
What's your great basic medicine in Springfield, Massachusetts? Did you have a tissue diagnosis on these before you operated? Have they been proven fibroadenomas?
As a routine workup, we do a fine respiration cytology, and they were all benign. We don't go for fibroadenoma, we just do cytology and we exclude malignancy.
I was wondering if, in fact, this came back as malignant, you made the wrong diagnosis initially, what would you do with those long tracks? And number 2, do you think all fibroadenomas have to be excised?
No, that's a very good question. This is only for those ladies who opted for surgery. As we all know, fibroadenomas in younger ladies, especially, can be kept under surveillance. But if a lady is keen on surgery and she has been advised surgery only as the option, only then they came to us in our surgery training. And we explained to them the option of being under surveillance or going for surgery. Again, the social issue of the unmarried ladies getting married and the married ladies getting some kind of negative comments from their husbands and their husband's family. This is what happens in India. They prefer surgery even for fibroadenomas. We explain to them the option of surveillance also. Second question, like we were very meticulous since this technique was not being done by anybody, and a lot of patients I lost because other surgeons will say, no, it's not possible, he may be speaking a lie. And so I compiled my data, only 25% of patients initially, like if I've seen 10 patients in my clinic, only 2 to 3 will come to me for surgery. In the later part of study, they started coming more frequently. So that is a question in my mind as well. If it is malignant, then what should we do? There is a track. So this is just a beginning. Maybe we can think of retrieving the specimen in permeable bag, or this is just a beginning. Only when we are 100% sure that it's immobile, clinically benign lesion and benign on final desiccation cytology, and there is no evidence on mammography that has been done of malignancy, only then we proceed.